Let's start today's episode.
Welcome back, period besties. Today we have Dr. Heidi joining us. We're so excited to have you. Thank you so much for being here with us. And
thank you for having me.
Yeah, it's so great to see your face. I've known Heidi for a very long time, but I haven't seen you since I left LA. So excited
I know.
to see your face. And
Same.
jump right in and talk about something that Stosh and I have been noticing in our practices, where women in their late early kind of menopause, or even like later menopause, are just sharing with us that they have to wake up all night to use the bathroom. What is going on, Dr. Heidi? Why are women noticing this as they're getting older? And why are some doctors just not really focusing enough on that and giving them the right support? I know it's a loaded question, but that's kind of the two prong of what we're seeing.
Sure. So, like, the definition of nighttime urination is nocturia. And basically, that's defined by having to get up 2 or more times a night to go to the bathroom and go to the bathroom. So, one time a night considered normal, but 2 or more where your sleep is getting disrupted, that is an abnormal amount of having to go to the bathroom. This can absolutely be something that is a component of going through hormonal changes and periods of estrogen reduction. So perimenopause hitting that, which usually is when it gets worse, more so than like postmenopausal. People start usually noticing those changes a little bit earlier when estrogen is first reducing, because then after we kind of level out, you may still have the symptom, it probably isn't going to feel worse at that point.
Okay. So they probably were noticing it, but also had hot flashes, night sweats, everything else. So
All of the other things.
It wasn't kind of on the high priority list of things to maybe even be able to focus on, honestly.
Sure. And also, just like other life changes can happen. So we can have that estrogen reduction, but then other parts of our life and things that are happening as we age may certainly worsen it and make it more of a high priority notice. One of those things being like if somebody is noticing that they're gaining weight, maybe we've been having perimenopausal weight gain, and at some point, some overweight status. Sorry, I'm trying to like figure out how to say that. If we're getting a little bit more weight and having more weight pushing down on the bladder, that can absolutely make it a little bit worse. Another thing is fluid retention. So if we've got somebody who's starting to experience fluid retention and like edema in their legs, that may be something that as we're getting older, we might be having something like that, might be a comorbidity with maybe diabetes or having some kidney issues or any myriad of things. We've had a recent surgery and I'm holding fluid on my knee after a knee replacement or whatever. If we're holding fluid in our body, that can actually make that nighttime nocturia feel worse also, because it's the time when we get our legs up and now our body's starting to reabsorb and process that fluid. And now we're having more nighttime urination because it's when our legs are up. There's so many other reasons for it, but definitely can be something that people feel like it gets worse as they age, but maybe something that is a comorbidity with something else they're experiencing too.
I remember looking at something that said that women tend to get up when they have kids or pets or something in the night, and so they pee while they're getting up in the night.
Sure.
And then it starts to kind of train them to get up and pee in the evening. Is there any truth to that?
So we can definitely train our bowel and bladder in a negative way. And basically, it's like we're training our bladder that instead of being like this full, that it's like when we get this full, we start noticing that like the urine or the bladder feels more full. And so we can train ourselves to have to go to the bathroom more and more. And one of those things is like think about throughout the day, the just in case piece. We just in case we have to go pee, we go to the bathroom. We try to keep people from doing that because now we're starting to train our bladder that instead of allowing my bladder to fill all the way, we're only filling to a partial capacity and it's starting to feel full. And so what you're talking about kind of is like in line with that just in case peeing, or I'm peeing more often because of circumstance and I'm not allowing my bladder to fill all the way. And then that could be part of somebody who has poorly timed voids or even a component of overactive bladder. And this nocturia, which we started talking about, is a not a symptom of overactive bladder. It is actually like a crucial part of overactive bladder.
Oh, interesting.
So it's like a hallmark, like that is like a hallmark part of overactive bladder is the nighttime urination.
Yeah, I grew up with a mom and she still does this, but we've always waited for my dad. Okay. So we would all get in the car and then he would finally come out and she's like, oh, well, now I have to pee again. So we all went back in the house, went to the bathroom, came back in the
Yeah.
car. So I feel like at a young age, it was wired in me to pee before you leave and all of that. And I remember, I can't remember who told me, but somebody when I was pregnant was like, whatever you do, when you get up in the middle of the night to feed your babies, do not go to the bathroom so that you don't start going to the bathroom. And like, yes, certain times I did, but I always ask myself, do I actually have to go to the bathroom or can I go back to sleep? So I found that
And I
really
think that's the actual question, right? Is like, do I actually have to go or do I just think I have to go? And are you ladies familiar with like Pavlov's dogs? Do you remember that from like high
Mhm.
school science classes and
Mhm.
psych classes? So part of that can become this Pavlovian like call and response. So like for me, I'll use myself as an example. I will get all the way home on my drive and I'll drive. I'm fine. I'm good. I don't have to go to the bathroom. But the second I see that front door and I know my toilet's upstairs, I gotta go. And I've got to go right now. And it's like an urgency. And it's something that I've been really working hard to train myself out of because I know it's totally psychological. Completely have the ability to get upstairs and go to the bathroom, but for a while I was leaking when I saw the door because it was like I literally would like see the front door and my body was like, and you gotta go. There was no reason I couldn't hold it. It was just like this absolute urgency. And it had become like a psychological response. So for you, train yourself that feeding baby does not equal going pee is totally different than I feed my baby. I actually have to go to the bathroom, right? Those are two different things. So we want to untrain the psychological and do things that are like sometimes even like with bladder retraining and pelvic floor PT, we teach people how to do things to help distract themselves so they forget they have to go to the bathroom. And remember, as like little kids, like you would literally do the potty dance. Like that could be one of them is like I potty dance to forget that I have to go. Crossing your legs or putting pressure up in the perineal body can help. And so if somebody really has to go, I'll tell them to like think about crossing their legs and kind of squeezing their inner thighs and try to like get that distraction of I don't actually have to go to hold it longer. That can be another useful thing to do. But when we wake up in the middle of the night, we're waking up from a dream, it's tough to tell myself that like I don't have to go, especially if I'm actually starting to leak, which is when our overactive bladder leads into that nocturia and we actually start to leak and we have that wetness. And that is something that can be really scary for a lot of people because I wake up and now I'm rushing to the bathroom and maybe I wake up and I'm already leaking and I'm rushing. It's a really high area for falls risk for people, especially as we're getting older. Or maybe I jump to get out of bed, but I'm holding my breath. And now I created stress incontinence on top of what's happening because I'm racing, like especially think like you're flipping on a bed, you hold your breath and you bear down. And maybe because of that lack of estrogen and because of maybe being a little bit heavier in my weight, or maybe because I had a childbirth a bunch of years ago that was never rehabbed properly, and I no longer have this like good control, like good solid bladder sling. Maybe my breath holding and that increase in intra-abdominal pressure is overwhelming what my urethra and my bladder neck can actually hold back. And now I have stress incontinence. And we can have that, and they're different things that they all play together. But this can be a big reason why we have falls with the population of people who are older in the middle of the night trying to toilet.
And in perimenopause, your ability to deal with
Mhm.
stress is going down. So that's just
Yeah,
compounding it. So do you see this at a certain point in perimenopause where it starts to happen more often, or age or anything? Or is it just like, well, when you get about halfway through perimenopause, your cycles are more than 60 days apart, we see it happening
Mhm.
more?
I've never seen any research that has to do with like a timing,
Mhm.
nor have I ever seen anything clinically that has to do with timing. Because perimenopause is really categorized by our estrogen really being wonky and going all over the place. It's not the time that our estrogen has just gone kerplunk. You
Right.
know, that's when we hit menopause, right? But just like that wonkiness and around is where we start getting those highs and lows. And that can lead into more of the GSM, the gynecological symptoms of menopause. And this is a component of that. And so, one of the things I really encourage people during perimenopause, even if they're not experiencing these symptoms already, is to consider going on topical vaginal estrogen because it's not systemic. It's safe for almost everybody. And that topical vaginal estrogen is what really is helping our vaginal tissues, our vulvar tissues, our urethra, and all of those structures on the outside remain healthier, more estrogen filled, plump, if you will, to help to hold back that tissue and really helps with managing a lot of the incontinence types of issues. And also is one of the biggest ways we have to reduce UTIs. Because if I am maintaining that tissue, it's a lot harder for bacteria to get up in that area. And so that helps with UTI reduction. And if we can start that early and with prevention, we really reduce a lot of those recurrent UTIs that can happen with age.
So good to know. That was one of our questions because UTIs become a little bit more prevalent in that age range too. So I've
Mhm.
been doing vaginal estrogen probably for a year and a half now, just as my doctor was like, your age, let's just start. It's, I'm going to be 47. So I was 45-ish. And she's like, let's just start. Um,
Mhm.
so I don't know. I'll knock on wood if that's what's helping me not, have any UTIs or any kind of incontinence at this point. But that was definitely something she's like, this is one of the best things to start sooner than later.
Absolutely. And I'm really happy that out here, I'm actually seeing a lot of my postpartum moms. I'm even starting postpartum moms on topical vaginal estrogen because it is not systemic. It's not going to go in the breast milk. So even if someone's breastfeeding, it's safe. And because postpartum is a time of really low estrogen as well, having that topical vaginal estrogen can help people recover from vaginal births faster with that like incontinence that we can have postpartum, with having people just avoid some of these issues then later in life that may happen because now I had this birth recovery that I never really recovered from. And I'm not saying everybody, but there's a lot of people who that then leads into a harder time in perimenopause and beyond with this GSM stuff because there wasn't a recovery. So it's essentially triggering kind of a recurrence of a previous trauma or injury now because we have the estrogens reduced later in life.
That makes so much sense though for postpartum.
Right. And I just started seeing this last year. I'm so happy about it.
That would have been helpful for so many people that I know.
Right. You
Yes. So
just like,
I know, like, hello. Question going back to kind of like, where do we start first? Like, do you start with the brain and trying to retrain that? Or do you start with pelvic floor when you're having nocturia? Am I saying it right? Nocturia?
yeah, Nocturia,
Yeah.
it's kind of potato, but great question. So when someone comes in for pelvic floor PT, when they come in for their first visit, and if this is a complaint or the complaint or a complaint in their picture, we're doing a lot of diving into symptoms and what they're experiencing. And one of the things that we ask people to do is that bladder diary if voiding issues are a problem on either side. It could be on the more like, I'm not voiding at all. I'm having incomplete voiding. I've got constipation. You name it. If it has something to do with pee or poop, we're doing some sort of a bladder diary. And with that, then we're kind of trying to siphon out where that starting point is. So some people, it's more behavioral. And when I say behavioral, I don't necessarily mean like a depression or like anxiety or something that's behavioral. But if we're dealing with something like, for example, your mom who's doing the just in case peas, it's starting to help people with bladder training. And that might be where we start. But oftentimes it is a kind of two-pronged solution or multi-pronged solution where we're doing that and we're trying to teach somebody how to manage their intra-abdominal pressure better. And so they're not holding their breath and bearing down. Or maybe we're teaching them how to maintain pressure from below. So, how do I squeeze and hold that up? Or somebody who's just really deconditioned in general, we're addressing that. Like I said, if I've got somebody who has edema, maybe when am I taking my diuretics, and dealing with timing of medications. Maybe we are doing something with like needing general conditioning of their whole body. I just don't really have any muscles to speak of, period, because somebody's been really inactive. And so oftentimes it isn't one or the other, but there's generally like a starting point, and we base that on the initial evaluation and generally like the results of a bladder diary.
I
I
like
like
that. I'm always a fan of tracking, charting, seeing what's
yeah,
going
you're
on in
really
reality. So it's one of the things we preach here very often. So that goes perfectly along with our from our pulpit on charting and tracking.
Yeah, and I mean, with the tracking, it doesn't even have to be forever. It's like we can
Yeah.
get 2 weeks of tracking. That's really all we need is to see what a routine looks like. And something from your side is one of the things we're tracking is what is someone eating or drinking? And what's the timing of that? Because one of the things that people really don't understand about overactive bladder, incontinence, also with nocturia, is that what you're eating and drinking and the timing of that can really improve our symptoms and really make a difference. And I'll share again with my own story is that I love sparkling water. Like I love carbonated water. I love Perrier. I love Zevias. Like love anything sparkly. And citric acid, which is what helps that carbonation be carbonated, makes my bladder just angry. And I can be completely fine and be having no bladder symptoms at all. And I can drink like a Perrier, just a single, like, the small little green bottle, and it completely sets off my symptoms. And it'll take me like a couple of days to get back onto a normal track. And so for myself, I have to make sure that like I'm really drinking more clear, plain water versus sparkly water. And there's a whole host of other things that, depending on the person, can be irritants. Citrus fruits, acidic foods, so like your tomato sauces can be big ones. Spicy foods for some people is another big one. Caffeine is the classic. Every person should look at their caffeine consumption and when they're having it. Because I'm not saying to stop drinking your tea, I'm not saying to stop drinking, your coffee, but if you're enjoying that later in the day and you're finding that I'm getting up to go to the bathroom all the time, or I'm drinking a lot of caffeine and I'm finding that I'm having to go to the bathroom all the time and I'm rewiring my bladder now neurologically to have to go all the time because I've irritated it, all of these things tie together. And dark chocolate, I'm not saying it's unhealthy, but it has caffeine in it. And so these are all things that, from like a dietetics point of view, if I'm working with a nutritionist or a dietitian, this is something that I'm asking them to double down with on patients as well.
Yeah, that makes a lot of sense. The coffee, I feel like, is such a big one. I personally cannot drink coffee. I do not
Mhm.
like the taste of it. I feel like I'm like one of none that feels that. But I do love my matcha. I do like my teas, but we're so tired. Like perimenopause is exhausting, the up and down hormones that so many of our clients are just grabbing onto that to get through. So a lot of the work that
Mhm.
we're doing is like, okay, let's water, food, then caffeine. Let's try to get you down to like 1 cup a day, really earlier in the day so that it's not affecting your sleep because it can just stay in your body up to 24 hours for women. It really
Yeah, the
can.
half-life's long.
Yeah, it can, depending on how sensitive you are. And I'm super sensitive to caffeine, which is why I don't really drink it. But it's just even changing that around really can help so much. My clients that are kind of in their 60s or retired, they like to have, their tea at night. And I'm like, okay, I know you love your tea at night, but I think we need to move that earlier because you can't drink a cup of tea an hour before you go to bed and then think you're going to make it through the whole night, unfortunately.
Yeah. And that's really great advice. We generally tell people like try to start water restricting like or fluid restricting 2 hours before you go to bed. So you have a full time for that to get through your body and to rid yourself of it
Yeah.
before you go to sleep. So then you're not waking up an hour later having to go. And if you have something that is too late at night and might also be a bladder irritant from you, you're just doubling down on it. And a lot of patients too, and I don't know if you see this, but I see it where people are like being told, and like I tell people this all the time if I'm dealing, especially with like a musculoskeletal issue, is like I'm trying to get people to increase their fluid intake. But then I see the nocturia start and rise up, and a lot of it is because people get to like 7 p.m. and they're like, oh my God, I've had 2 cups of water. I've got to catch up. And then they pound an entire liter at night. And I'm like, no, 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 no. Now we're just like adding insult to injury. So number one, now you're just flushing everything out and you're going to bed. So now we're not sleeping. So timing of drinking and like when we drink is really important for people too. And they forget that. So there's so many nighttime behaviors that we can be correcting to really help make this an easier deal.
I remember seeing something about if you are trying to hydrate, that
Mhm.
chugging a bunch of water all at once is absolutely not the way to do it. You need to
It is not.
space it out throughout the day, right? Because I have this, I'm going to take this clip and I'm going to send it to my husband
Yeah.
because we have this argument all the time where I'm like, just pounding 3 glasses of water after dinner is not hydrating, right?
Hmm. Yep. You want to sip it throughout the day because number one, if you drink a lot, it's just going to flush out, and that's going to flush out your electrolytes too, which that can be really like scary for your heart. You've probably heard that people can like have hyperhidrosis where they drink too much. Like you hear the bad cases of the football player who drank an entire gallon of water and had a heart attack like on field. And it's because people like just completely replete their electrolytes and like just wash them all out. And that's dangerous too, because that has effects of sodium, potassium on our heart and calcium. And so we don't want to be chugging a bunch of water. And I'm not trying to just to scare people, but that's a really like kind of extreme example. Someone drinks a gallon of water and they have a heart attack. Okay. But just knowing that drinking all of that one time, it can flush our electrolytes out. It can also really upset our body's way of creating its own stressor because now I just put all of this fluid in and that can be dangerous for us too. So instead of pounding it, we want to sit throughout the day. So in general, like what we are telling people at this point in time is that about half of your body weight in ounces of water a day is what you're aiming for, but throughout the day. And if I have someone who comes in, like my little old ladies who come in, and a lot of them come in with stroke-like symptoms, and it's because they are malnourished and they are dehydrated. And if I'm trying to get somebody to eat and drink more, I'm not saying we're going to go from one little like Dixie cup of water to 2 liters of water in a day. We're doing that over months of building that up. We're not doing that fast. And if I've got somebody who is an incontinence patient, a lot of these people are water restricting already, and their urine is actually more concentrated, which then acts as a bladder irritant. But if I go from, again, a Dixie cup because I'm water restricting because I'm afraid I'm going to pee my pants to 2 liters, that's bringing us to the other end of the spectrum. So it's a slow, steady increase. It is not a all in one sort of a solution, but we are trying to increase it because we need that urine to be a little bit more dilute. And we're playing with things with their urine. What can we do to make that like less irritating on your own bladder? And so we all heard like cranberry juice. For some people, cranberry juice does kind of help. It can be a little bit calming. Cranberry capsules can be calming for some people, not everybody, but a lot of it is in just moderating what they're changing in their diet and what's actually going into the urine that's making a difference, which makes me want to bring up this point. Perimenopause, stress, drinking, moms, red wine.
Oh, yes.
I'm really sorry how many people are going to absolutely hate this, but nighttime, okay, perimenopause, our hormones are all over. Okay, we're having to pee more in the middle of the night. We're super stressed out. Now we're having hot flashes. You've got to try to get rid of the red wine. I'm so sorry, but you really do because the red wine acts as a vasodilator, is going to make you hotter. The alcohol is going to make you hotter. It's going to make your sleep worse. You've got to try to get rid of it. The acidity and irritation in your bladder is making you have to pee at night. It's all just a perfect storm of terrible. So I'm really sorry to tell you, but this is really truly a thing. And red wine is probably the worst of them.
I can already hear
I'm
people going,
sorry.
okay, well, then I'll just drink white wine.
Yeah, I mean, it's all acidic, right? And it's not just the red wine because it's red wine, but it's also the alcohol. And so really, I know people want their alcohol. It's just like me with my coffee, but it's just reducing it. Try to reduce it. Try to get down to one drink a day. Try to maybe only do it on the weekends. So in a day you don't have to be super awake and alert the next morning in case you did have a hot flash and have to wake up in the middle of the night to go pee, because then it's just a nasty downward spiral. And I never force anyone to get rid of it, but it is something I strongly suggest people make that lifestyle change.
What about switching it out for like a gummy, a little can of gummy instead? Or is that
Yeah.
also a vasodilator? I have no idea.
So cannabis is not a vasodilator. And so if we're talking about something like a CBD, CBN is like the cannabinoid that like is most known for helping sleep. So like a CBN gummy at nighttime, to the best of my knowledge, there is no direct correlation with that and increased urination at night. The one thing I would suggest though is if you take that and you go to bed, then go right to bed. Because if you're somebody who gets dry mouth and then you start drinking water, it's probably not going to really help. So if you're somebody and like CBN and CBD and CBG, all of those cannabinoids are not the part that gets you high. But I do have a lot of people who are very sensitive to cannabinoids and still experience things like dryness or like the munchies, even though there's not the THC. So if I'm eating and drinking a bunch after I took my gummy, it's probably not going to help me. So it's like take your gummy, put your head on your pillow, close your eyes, not wait for it to kick in, and then close your eyes, because at that point you're probably be raiding the kitchen or might be. So that would be the one thing I would caution.
I have a little dropper that has a combination
Mhm.
of CBD, CBG, and CBN in it, and it's on my nightstand. So it's like I take my nighttime vitamins and all that stuff, trying to do it earlier so that I'm not drinking the water to take the nighttime vitamins,
Mhm.
it's close to bed. But then that way I can climb into bed, do my drops, and then just right out
Yeah.
into space.
And that's a good point. There's some people who need to take a med right before they go to bed, right? So we tell people, if you have to take a medication right at bedtime, just a little sip of water, just enough to get it down, not like then gulping the whole glass. Or if you're thirsty right before you go to bed, it's like if you have that, your water at night, like swish and spit,
Mhm.
right? Versus, and just wet your whistle literally, versus like drinking a whole cup, or just have enough to like coat your mouth and your throat and not then be drinking a lot. Because I understand that I'm absolutely a nighttime dry mouth person. And that's something that I'll swish and spit, because that sounds so gross. But it helps me from like not having that dry mouth where then you're laying in bed going,
Yeah.
Yeah, that's the
One of
worst.
sure,
my
that's let's not make that a clip, okay?
No, one of my sleeping meds that I have gone on in perimenopause because the insomnia was winning the battle. But it gives me the worst dry mouth. So I am trying to take it right before I go to sleep with the least amount of, so I'm trying to do all of the other things that don't knock me out earlier, like right after dinner, so that I just have that one med and I can take right before I go to sleep with just the least amount of water possible, and then my CBD drops, and then I'm like, okay, I will be asleep in half an hour because this combination will just put me to sleep, and then I'll sleep through the night, but I don't because I don't want to get up to have to pee. I'm like, I
Yeah.
finally am getting sleep again. I don't want to screw it up.
Right. No, and again, if you have to get up once, right, and then you're able to lay back down and go right back to sleep, then like that's not considered an issue. But if it's disruptive and or you're getting up two or more times, that's when we're kind of categorizing this as a problem, and people are sleepless and tired. And if you are dealing with insomnia, like any disruption can be disruptive, right? You get up one time and now you're up for the night, and we don't want to see that either.
Yeah,
That's
I
my
mean, I
problem.
think that's the problem. Like if I get up, I'm up. So I
Mhm.
just
Same.
like go back to bed, Katie. Just to talk a little bit more just about pelvic floor, with declining estrogen happening, there could also be an increase in painful sex. And I hear that from some of my clients, and I'm always like, pelvic floor PT. Talk to us a little bit more about what's happening. I know you touched a little bit on the vaginal estrogen, but from a PT perspective, how can women going through peri to menopause kind of help decrease the painful sex that they're experiencing, if they're
Sure.
experiencing it?
Sure. I mean, it's a really common thing, and there are a lot of different tacks to take depending on the person. So, again, vaginal dryness and loss of vaginal tone are part of this whole symptom complex we call GSM. And the reason for that is the reduction in estrogen is literally making the collagen and elastin and other parts of our tissue that make us plump and full. And think about like pulling the lines out of my face, like pulling my vaginal tissues tight and making them plump. That is going down, or it's become really erratic. And so a lot of women might even think about, I was postpartum and maybe I wasn't ready to have sex because I was still healing from a vaginal birth, but thinking about how their tissues may have changed during that time as well, or having a similar thing happening during perimenopause and then in menopause, where the tissue is just, the structure is not as sound. And that can lead to things like dryness, that can lead to things like vaginal fissuring, that can lead to just less tissue integrity, all of which can make sex painful. And the two things I would say, number one is lube. Like, just don't be afraid of lube. Increase lube all the time, whether you're self pleasuring, you're with a partner, whatever. We want to protect that tissue. So lube is really your friend. And I can't stress that enough. For some reason, there's like a weird bad connotation with it, and I don't know why. And then find one that you like. There's water-based, there's silicone-based, there's oil-based. Just realize that not all those things mix. So perimenopausal women can still get pregnant. So if you're using a barrier method like a condom, You don't want to use an oil with that because you might have a condom break. And then if you are using that as your mechanic, you could potentially have a failure there. So just being aware of things like that, I think, is important. But that being said, lube is kind of the first thing I tell everyone. If you don't have some, let's get you some. Let's try a bunch, figure out which one works for you. The second thing is that topical vaginal estrogen, again, really helps with the tissue integrity. And again, it is a form of hormone replacement, but it's not systemic. And so it is safe for almost everybody. And I say almost because there's always that one person for whatever reason, but topical vaginal estrogen is something that I really encourage women to have conversation with their healthcare providers about because it does have to be prescribed. Those are two things for sure. The third thing is literally looking at the tissues off the pelvic floor PT and going, okay, what's going on with my tissues? Am I holding a lot of tension? Again, we talked earlier about perimenopausal women, we're stressed. If I'm holding tension in my jaw, I'm probably holding tension in my pelvic floor. And if I'm holding tension in my pelvic floor and everything is tight, and then I ask it to expand because I'm trying to maybe have like some sort of penetration type sex where something is being inserted into that tight vagina, it may hurt because I'm asking something that's being holding tension to stretch in a way that it doesn't want to do. And in which case, we may need to be doing pelvic floor PT things like teaching someone how to self pleasure and doing self massage, like intervaginal massage, or if they don't want to go inside for any number of reasons. Number one being it hurts. Number two is just not a personal choice. They don't want to have something going inside. Doing massage to our inner thigh muscles, doing external massage and stimulation to help those tissues to relax, teaching people breathing mechanics and breathing breathwork exercises, teaching people downregulation and stress reduction techniques, all can be part of someone's pelvic floor PT routine. And then if we're talking about partnered sex, and it doesn't matter if it's like what type of partnership we're talking about, but if this involves something into vagina, so some sort of penetration, we may be needing to talk about positions. And we might be needing to talk about what positions can help or hinder this for that individual. And that is not a universal thing. There isn't one position that is a winning thing. That's a very personal thing, but that's something we can help someone figure out. If it's deep pain, where it's like a collision type pain, like at the cervix, there is a device designed specifically for that. And there are sex positions that, again, can help with that deep pain. So if it isn't really entry pain, if it's deep pain, those are different types of pains and need to be treated differently. And these are all things that we do with pelvic floor PT and related in relation to pain with sex.
Ah, it's amazing. I love it. I have to say though, I watched Best Medicine recently, this show
I
that
haven't
just
seen it.
came out.
Okay.
So the guy has a client, he moves his towel. Anyway, this client comes in, he's like, I have man boobs. What's going on? And then
Okay.
he finds out that his wife is using a vaginal estrogen cream and she applies it liberally before sex as a lube instead of lube, right? And he goes,
It
I
is not
figured
lube.
out why you have man boobs. And then they figure out she's also having an affair because another guy comes in and is like, I have man boobs, what's going on? And then anyway, as you were saying that, I just could not get it out of my
This is what's
head.
happening in your head. But yeah, well, we should definitely say that, topical vaginal estrogen is not lube. So it's like, well, those are two separate things. And there's also vaginal moisturizer, which is not lube and is not topical estrogen. So if someone's looking for a non-hormonal option and or they're combining things, like I use all three, but a vaginal moisturizer is like a face moisturizer. We're literally adding things like hyaluronic acid back into the tissues and helping to increase and stabilize that kind of skin barrier on that like submucosal tissue. And it's important to say submucosal because, when we're talking about like the skin that's like on my thighs and on the outside of my vulva, that is a different skin than the inside of my vulvar tissue, right? And so I'm not going to necessarily use something on my thighs that I'm using like on my like vulvar tissue. And that's where something that is made for that is an important thing to distinct because we want to make sure we're not putting things that chemically irritate that skin as well and things that we want we want to know that everything we're putting there, we need to know it's going to be absorbed in our body. That tissue is so highly absorptive, which is why for a lot of women, I tell them, like, if I'm not going to put it in my mouth, I'm not going to put it in my vagina because what my oral lining of my mouth absorbs, and we think about how much that absorbs, my vaginal tissues and my intervolar tissues are the same way. And so if we think about that, like I don't want something getting absorbed in those tissues that's going to create more pain and irritation. So there's a lot of things on the market. Medicine Mama is a really popular one. I work with a group called Taboo Group, and their moisturizer is one that I personally use. Kindra has one. There's a lot of them on the market, and a lot of it has to do with like, what is your preference? Do you like something that's kind of thinner? Do you like something that's more of a balm? And it really comes down to personal preference versus one being better than the other.
I love that there's options now. That's
A lot of options.
fantastic.
And
I've
there's one
also,
with CBD in it too.
oh, well, there we go. That'll help with the endo.
Yeah.
Okay, so something that, on the old TikToks and social medias that's been coming up these days is that perimenopause and postmenopause, the lack of estrogen essentially is pulling, like reducing the size of the inner labia. And some people are saying like they disappear completely. And you know what? Let's clear up the social media information generator and tell us if that's true. Like, should we be in perimenopause going, okay, bye inner labia, we'll see you next lifetime? Or like, is this a personal? Tell us all about it.
I know exactly which very scary TikToks you're talking about because I get sent them by not my patients, but my girlfriends at like 2 o'clock in the afternoon. And I get the like scary 2 p.m. like doom scrolling, my like labia disappeared TikToks and my text stream. And for any of my girlfriends, if you're watching this, you know who you are. But yeah, so here's the long and short of it is that yes, our labia minora, our inner lips, can kind of disappear when we get older. It doesn't happen to everyone, but it does have to do with estrogen reduction. And what happens is when the estrogen is getting reduced, is that tissue essentially is being kind of reabsorbed into the body because again, our tissue structure is changing with the estrogen reduction. It doesn't happen to everyone, and there's nothing wrong with it, but it's something that you may notice that over time, they just get smaller, and maybe you notice that they're just not really present anymore. It's not like you wake up one morning and like poof, like no more inner lips. Like it's not that dramatic for people. It's just this might be with over time. And if you notice that you yourself have like smaller labia minora, which if you haven't compared to a lot of vaginas, like I see vaginas all day long, right? So they're all beautiful, they're all different, but some people have bigger, more robust inner labia, other people don't. And if you don't have as much tissue there to begin with, you may have less tissue there as you get older. It may just be that is how your genetics change. Now, I don't know that there's any research saying that topical vaginal estrogen will make them not disappear. But if you think about how, like just anecdotally, if I'm using topical vaginal estrogen and that tissue is being more plump and firm, I think that we may see if someone studies this over time, maybe those people don't have as much of a reduction in the labia minora. But I wouldn't say that's a reason to use it. It's just maybe something if you are using it that you could kind of pay attention. Do I have that symptom or do I not? But I don't think it's something we really need to worry about. But it is something that is really a big doom scrolling part of TikTok of my, my labia have disappeared. And it is a very scary thing because people are not talking about it. And then you see it that post and it feels very, very scary.
Right, like at least give me a heads up if that's going to happen.
Right. I know. And like you don't want to learn that from TikTok. You like to learn that from like your medical provider, right?
What about HRT though? If you're taking estrogen, does that have an effect on that, or just the vaginal estrogen maybe?
So with HRT and with topical vaginal estrogen, so HRT, when we're taking it systemically, it's affecting tissues head to toe. Again, I don't think that there is a research study yet that says you that it's like a one for one. You take HRT and you're taking those and your labia don't disappear. Again, with the prevalence of this on social media, I wouldn't be surprised at all if someone does do a study on this just to have clarity because we all do care about these things and it's something that is going around a lot. But I don't think that we know yet if there's a correlation between those. But what I can tell you is that if you're taking systemic HRT, if you are having like GSM symptoms, it is really suggested that you also use the local because the local are going to have more effects on the vaginal dryness, on the incontinence, on the UTIs than the systemic will. And so with those two things, you're layering those treatments on top of each other.
That makes a lot of sense, actually.
Okay, so before we start wrapping up, I just have
Hmm.
one personal question, which is
Sure.
what is your daily health non-negotiable? Like the thing that you do most every day that is really just the thing for your best self, your best health.
Sure. Very easy. I get outside and I walk my dog several times a day off my phone. I make sure that my vision is opened up. I'm looking at the world. I'm lucky enough that I live somewhere I can see the ocean. And this is my office. I can see the ocean from where I am. And I make sure I get outside. I open my eyes. I get off the devices and I just walk and move. And not at any like, I'm not trying to walk super fast. It's kind of his pace, it's his walk. But I find that helps my stress, it helps my blood sugar, it helps my cortisol, helps me manage my weight, helps my stress management, like all of the things. I feel like it hits all of the highlights. And that's my daily non-negotiable is getting out and walking with my dog. And that has carried me through cancer, chemotherapy and radiation, perimenopause, menopause, and just like now being postmenopausal. And I'm like 2.5 years postmenopausal at a very early age because of chemo. I found that doing this every single day just helps to keep me really regulated and on a good track. And so it's become my non-negotiable for the last 5.5 years.
I love that. I love a good
So,
walk. Stasha does
yeah,
too. It's one of the best stress reducers I have, I feel like too.
it's free medicine.
Yeah.
Yeah,
All the
Yeah, so that's
flora.
mine.
yeah, absolutely. We're outside the national forest, like our backyard. It basically
Ooh.
connects to the national forest. And I just, every time I go out there, I think of the Japanese forest bathing, where it's literally a prescription that your doctor may prescribe to you. Go spend time in the forest. And I just think every day when I'm out here, I'm walking the dogs, I'm like, I'm getting my free forest bathing in today.
It's so nice. I mean, that was a term that I hadn't heard until pretty recently. And I realized that like I've loved my entire life. I grew up with a cabin in northern Minnesota and did forest bathing as a kid. We were being naughty. They threw us outside. Don't get eaten by bears. Just like go play in the forest. Yeah, I mean, it's like calms you down as a kid, and like it still calms me down now as an adult too.
That's
Watch
a
out for
good
bears
one.
though. I was
Yeah.
just going to ask if Katie, if she'd heard that there were black bears back in the Santa Monica Mountains since she moved away.
No, I did not know that.
So
There are bears in my neighborhood though.
Yeah.
nice.
I have alligators, bears, deers, fox, turtles.
I will say
And
all of those except for the alligators.
I think the alligators are so cool. Whenever they're not like whenever they're out bathing, I'm like, okay, yes, spring is here. I'm like, okay, we made it through the winter. Like they're out, they're ready to go. They don't bother anybody. The only time they come
Yeah.
out of the ponds is during mating season. And that is a little scary because they literally will walk down the street looking for their mate, and that's a little much. And everybody just sends photos on Facebook, like, don't go near this pond. The alligator's out looking.
Can you please tag me that so I can see it? Because I'm like, I think it's one of those exposure things, right? Like I'm not exposed to it here. And so people here are like super scared of sharks, right? And I'm not because I've been exposed to them so much. I know that they're not a scary thing. This sounds like the flip where I'm scared of gators and you're not. And I'm like, please give me more exposure therapy.
Well, when we first moved here, I was like, wait a second, what do you mean like, in my neighborhood pond? Like that doesn't make sense to me. We shouldn't be this close. But they're not the Florida Gators, which are crazy. My good friend of mine who grew up here, she told me when we moved here, don't worry, they're not going to chase you. They're not going to come in your yard. They're not Florida Gators. Those Gators are crazy. It's like,
Which I can attest to because I've been going to Florida every summer since I was a kid. We had a lot of family there, and now my parents live there. And my uncle had a huge fence between his yard and the pond, and he would throw chickens out there and stuff. So we would come over, and he'd be like, "You want to see the gators?"
yeah, you're not supposed to feed them. You're not supposed to
No,
feed them.
you're probably not supposed to feed them there either, but it's Florida man.
Yeah, but yeah. So any of those
Was
crazy
it
was it Gainesville?
was it Gainesville?
No, it was Panama City.
Okay, because my parents went to school in Gainesville, and there was a guy that they later called Gator Man, who fed the gators on a pier, like that went out into a lake by campus. And I was like, wait, this cannot be the same human, like 40 years later. Like, I wouldn't be surprised though. If you're like, I know Gator Man, I'm like, my parents knew Gator Man. Like, it would not surprise me with how small this world
This
is.
was probably 40 years ago. I mean, it was when I was a kid, so.
Well, this guy was in Gainesville, so unless there was two, there could be
Yeah.
more
Oh,
than one Gator
there's
Man, right?
a lot of them, I promise you.
The Gator men, plural.
Yes,
Not,
exactly.
not a Gator man, Gator men. Yeah, let's not feed the Gators, people.
Yeah.
No.
I mean, we are in their world, but we could go on about this nature topic forever.
Oh, for sure.
Yes.
I'm thinking back to your first thing, like you were told that not to go pee in the middle of the night when you breastfeed. And I'm like, yeah, we're not peeing in the middle of the night when we breastfeed, and we're not feeding the Gators. Like,
Yes. We're not feeding
why we
gators.
just kind of all came full circle there,
It,
at
I
least in my brain.
love it. So before we go, tell
Mhm.
people how to find you.
Sure. So I'm a pelvic floor physical therapist in Manhattan Beach, California. I do see people virtually nationwide. So if someone's looking for me nationwide, and if you can't find a pelvic floor PT that resonates with you in your area, I'm more than happy to work with you virtually. And I'm very honest with people. If it's something that's beyond what I can help them virtually with, I will do my best to help them find someone in person in their area. But the easiest place to find me is on my website, which is heydrheidi.com. Heydrheidi.com. And that's probably the easiest place to find me. And that kind of link trees to all my other things.
Awesome. Yeah, we'll put everything in the show notes.
Perfect.
All right. Before we go, we have
Oh,
a fun little lightning round. So go with your gut.
Okay.
We're going to ask you questions so people can get to know you a little bit more.
All right.
All right. So
Ready.
the first question is, what is your favorite junk food?
Nurse clusters.
all right. What is your favorite
Problem.
series?
TV series?
Mhm.
Right now, The Pit.
I just started watching that. Just saw the first episode.
Heard
Can't
so
stop.
much. I don't know if I could watch it.
It's a lot.
Yeah, maybe a few years from now. What's a household item you can't live without?
Dyson vacuum because I have a dog.
Yeah, I would say our Bissell wet mop because we have two cats and two dogs, and it's just, oh.
Same thing.
Right?
Same. Yeah.
Um, do you take naps?
No, not a napper. Never have been. Yeah, I wish I could. I'm not good at them. It takes me too long to fall asleep. And by that time, it's like next, like next project's already here.
Yeah. All right, last question. Your
Okay.
favorite vacation spot?
If I have to pick one, I'm gonna say Telluride, Colorado for skiing.
Yeah, I lived in
Beautiful.
Breckenridge for a while. I love it up there.
It's gorgeous. I love Breckenridge.
It was so wonderful to see you. Thank you so much for joining us. And for everyone
Thank
listening,
you.
go check out Dr. Heidi, and we will see you in the next episode. Thanks for listening.
A big shout out and thank you to our sponsors for today's episode, Period Coaching School and Katie Bressack Wellness.
Thanks to you, our favorite bestie, for listening to the Period Besties podcast, where no topic is TMI. And of course, share this episode with your besties.
Remember to leave us a 5-star review, nothing less than the best for us besties, and subscribe wherever you listen to podcasts.
You can follow us on Instagram at Stasha Washburn and at Katie Bressack, or email us at periodbestiespodcast@gmail.com.
Check out more about us at katiebressack.com and periodcoachingschool.com. And of course, check the show notes for free goodies and extras that support this episode.
We'll see you on the next episode.
Bye for now, besties.